Hello, Namaste students. Today we will be discussing about one important case for both undergraduate students and postgraduate students for their exams. And this is one very important case which all the undergraduates and all the postgraduates should know about it. Okay. Here is a patient by name X, age about 42-year-old. He is from Chikkaballapur, studied till 12th class and he is a businessman by profession. History given by the wife and it seems to be reliable. Chief complaint: right-sided weakness since 2 years, difficulty in speaking since 2 years. So I repeat, the chief complaint is right-sided weakness since 2 years, difficulty in speaking since 2 years. History of presenting complaint: patient was apparently normal 2 years back when one day suddenly he developed weakness of the right side of the body one fine morning while walking inside the home. Weakness was sudden in onset, both right upper limb and lower limb involving it. He says there is history of headache and there is one episode of seizure which is present just preceding the weakness. According to wife, there was a seizure. Now, after the seizure, within few minutes, he noticed the weakness of the right upper limb and lower limb. The seizure was focal only, involving the right upper limb. Patient gave history of headache the previous night also to the wife, but headache was not associated with any nausea or vomiting. Patient says he had a sensation of giddiness, okay, and then he also felt drowsiness at that time when he had a headache the day before the onset of the weakness. Then when he developed the weakness of the right upper limb and lower limb the next day morning, he was immediately taken to the hospital and there he was hospitalized for 25 days. There was a facial deviation towards the left side according to the wife. There he was not able to lift the right hand above the head or comb the hair. So there was a proximal muscle weakness in the right upper limb. Also there was a distal muscle weakness in the right upper limb. He is not able to mix the food, button or unbutton the shirt. And he was not able to hold the chappals in the lower limbs, and also he was not able to get up from squatting position from the sitting position. From the squatting position he couldn't get up, stand. So there was both proximal and distal muscle weakness in both right upper limb and lower limb. Initially he was disoriented and so couldn't able to elicit any sensory complaints from the patient. But later, once he developed the proper orientation, he could appreciate the cloth on his body which indicates a fine touch. He could appreciate the hot and cold water sensation over the body which indicates pain and temperature. So both pain and temperature and fine touch is normal over the right side of the body, whichever side he complained the motor weakness. So then the weakness, whatever he had, he underwent treatment. Since the last 2 years, what was the weakness was a total weakness of the right upper limb and lower limb. Now it has improved till grade 4/5. He could lift the hand above the head. He can walk even without support, but still there is a mild weakness is present. So there is an improvement in the weakness. So this mode of onset is important in the history students because and during which time of the day the weakness appeared, that history is important. Mainly cerebrovascular accidents are classified into atherothrombotic, embolic and hemorrhagic stroke. The mode of onset during the activity in the daytime, if it is there, then it is embolic or hemorrhagic stroke. Thrombotic stroke, usually they will go to the sleep the night before and then they get up with the stroke, thrombotic stroke. Then the weakness, whether it was maximal at onset and improved like him. So weakness was maximal at the onset and later it improved slowly over the years. If the weakness is maximal at the onset and it improves, it is a embolic stroke. In a hemorrhagic stroke, if improvement occurs, it rules out hemorrhage. Hemorrhagic stroke never improves the weakness. In a thrombotic stroke, the weakness will either remain same or worsen. So the mode of onset, the progression of the weakness is important in the history to whether it is atherothrombotic, embolic or hemorrhagic. Before going into these three types of strokes, first I should tell what is embolic means. Embolic means artery to artery there may be embolism. From the carotid artery, embolism may be thrown to the MCA, ACA, or from the cardiac embolism may throw into the ACA or MCA. Atherothrombotic means there can be a in situ thrombosis of the ACA, MCA territory, there can be in situ thrombosis. Then hemorrhagic, the blood vessel may rupture due to so many causes which I will discuss in the end, can produce hematoma. These are the three types of strokes. Then you would ask history of headache, nausea, vomiting goes in favor of raised ICT, which is a feature of hemorrhagic stroke. Then altered level of consciousness. Normally, if it is a ischemic stroke, unless the whole of the cortex is involved, their conscious level will be normal. Whereas altered level of consciousness is a feature of hemorrhagic stroke. Either they can be drowsy, stuporous or comatose. So level of consciousness. Then history of seizures, which we had asked in this patient like him. Seizures is a feature of either embolic stroke or hemorrhagic stroke, especially lobar hemorrhages, but not a thrombotic stroke. History of seizure history. Then you have to ask any history of past history of TIS, transient ischemic attack. You have to ask whether he had a similar episode in the past in any case of stroke. Transient ischemic attack is the focal deficit which will last less than 24 hours. Usually most of the TIS will last for less than 1 hour. TIS can be in the anterior circulation or a posterior circulation. Anterior circulation means anterior cerebral artery and middle cerebral artery. Anterior circulation TIS, usually they will have a facial weakness or facio-brachial weakness. Posterior circulation TIA, which supplies a midbrain brain stem. You have a cranial nuclei, 3rd, 6th, 9th, 8th. So they will have diplopia. It supplies cerebellum posterior circulation. So they will have ataxia. 8th nerve. So they will have vertigo, giddiness, dysphagia, 9th and 10th nerve. Hoarseness of voice due to 10th nerve. So diplopia, ataxia, hoarseness of voice, dysphagia, these symptoms you would ask posterior circulation TIS. TIA is a feature of atherothrombotic stroke. You have to ask history of TIAs. TIAs, I just want to tell little points about TIA now history only. They have been classified into large vessel low flow TIAs, embolic TIA or a lacunar TIA. 10 to 15% of the patients with the TIA will develop the stroke. Who will develop the stroke in TIA is guided by ABCD2 score. A, age more than 60 years. B, blood pressure more than 140/90. C, if there is any weakness, then it is given 2 points. Only if there is a aphasia, speech disturbance, it is given 1 point. Then D, duration. More than 60 minutes, 2 points. 10 to 59 minutes, it is 1 point. And then one more D is diabetes. So ABCD2 scoring, who will develop the stroke in transient ischemic attack. So it asks history of transient ischemic attack in any stroke patient. Students, he is not giving any history of transient ischemic attacks. Then symptoms of facial involvement, whether any angle deviation is there, he gives history. The wife told the facial deviation was there. Symptoms of lower cranial involvement. Which are the lower cranial involvement? 9th, 10th, 11th and 12th. Dysphagia, hoarseness of voice, dysarthria, nasal regurgitation. These symptoms you have to ask in any stroke patients, just to rule out whether he has developed any posterior circulation stroke or not. These points you have to ask in the history. He is 42 now. When he developed the stroke, he was a 40-year-old. So there comes a stroke in young. You have to ask some relevant points. Okay, why he has developed a stroke at such a young age. Okay, so some of the points which we have asked in the history is, so there is no history of any loose motion or vomiting because that dehydration can produce thrombosis. So that history you have to ask. Then cardiac causes. Okay, so it can produce atrial fibrillation, mitral stenosis with embolism. Okay, so you have to ask any cardiac symptoms is there. History of any chest pain, palpitation, orthopnea, PND or pedal edema. Any cardiac symptoms is there, you have to ask in the history. Whether patient had any fever before, okay, meningitis can produce stroke in any age due to vasculitis. So history of fever, even bacterial endocarditis, fever can be a feature and embolism can be thrown by bacterial endocarditis. Then history of headache in a females, especially middle-aged females, they can develop migraine. Migraine can produce a focal deficit that is known as complicated migraine, hemiplegic migraine, which will improve. So history of any chronic, recurrent and coming episodic headache history you have to ask. History of joint pains, rashes over the body. So SLE, connective tissue diseases can produce vasculitis, producing stroke in young. So you have to ask that history. Then any nephrotic syndrome features like facial puffiness, which is a hypercoagulable state, whether he had, you have to ask. Then any respiratory symptoms like sinusitis, vaginous granulomatosis can produce vasculitis and stroke. Then any symptoms like weight loss or loss of appetite because systemic malignancy is a hypercoagulable state. So you have to ask that point in the history. Then sickle cell anemia, thalassemia can produce be due to hypercoagulable state, the stroke. So past history of repeated blood transfusion is there, you have to ask in the history. Okay. So some of the other features as I told, so cardiac symptoms, fever, then in the drug history I will come back again. Drug intake you have to ask because the illicit drugs like cocaine and amphetamine can produce both ischemia and hemorrhage, can produce stroke in young. Then family history, stroke runs in family especially if they have inherited hypercoagulable state. So family history is important, which I will discuss again. Then diarrhea is important not only due to the dehydration and thrombosis. Inflammatory bowel disease is a hypercoagulable state. So history of diarrhea is important in stroke patient. So headache history due to migraine and meningitis. Then suppose if it is a female, especially stroke in young, eclampsia can produce stroke in young. Then cortical venous thrombosis postpartum can produce stroke in young. So you have to ask that history. Then any history of trauma, dissection can produce at any age, okay, especially vertebral artery, basilar artery can undergo dissection, so you have history of trauma. These are the points which you have to ask in the history, especially if the stroke has occurred at a very young age like in him. Then whether facial nerve, the wife told deviated to one side, whether it is LMN or UMN, how do you ask in the history? LMN upper part of the face will be involved. If upper part of the face is involved in the history, there will be epiphora because the eyelid cannot hold the tears. So epiphora history they will give if the element facial nerve is involved. So these are the points which we will ask in the history, okay, whether it is thrombotic, embolic, hemorrhagic, or whether any causes for the stroke in young is there or not in this case. So students, coming to the past history. Past history, no history of similar complaints in the past, similar complaints. He was diagnosed to have hypertension since 5 years back prior to the onset of these symptoms, but he was on irregular medications. And one important history what he says is he has not taken the medicine 20 days prior to this episode. No history of diabetes mellitus or thyroid disorder. No history of prior blood transfusion as I told in the history. No history of transient ischemic attacks. No history of any fever or joint pains. Okay, it's not there. So which are the conventional risk factors for stroke? Old age, hypertension, diabetes, smoking, hyperlipidemia. These are the conventional risk factors for stroke which they can have. That you have to ask in the history. Personal history, he used to take a non-vegetarian diet. Bowel and bladder habits are regular. Sleep and appetite is normal. He has only occasional habits of alcohol intake and smoking, but he is not a chronic alcoholic or not a chronic smoker. But he stopped even that also since 2 years. Family history, no history of similar complaints in the family. No history of, as I told, sickle cell anemia or thalassemia in the family, or no hypercoagulable states. Drug history, he is taking antihypertensive medications but stopped it 20 days before the onset of this episode. And no other history suggestive of any illicit drug usage. So this is the history. Now, how do you analyze, students? So, this is sudden onset. Sudden means vascular. The brain diseases are classified into acute, subacute and chronic. It is acute means vascular. Subacute infections, nutritional diseases are subacute over weeks to months. Chronic over the years, for example, Parkinson disease, motor neuron disease. The mode of onset is important. The mode of onset sudden means it is vascular. So, it is a cerebrovascular accident. That is the first diagnosis. Next, whether thrombotic, embolic or hemorrhagic. The weakness improved. Probably we can consider embolic, but there are some features which are even suggestive of like hemorrhage, he had a headache, altered sensorium. Probably I would consider the headache and altered sensorium due to hypertensive encephalopathy which he had because he stopped taking 20 days medicines before the episode. If the stroke is due to the hemorrhage, it should not have improved like in him. So probably he had hypertensive encephalopathy. Then a cerebrovascular accident, probably embolic. Which territory is involved? It could be cortex or it could be internal capsule. He has a speech disturbance according to bystander. Whether it is dysarthria or aphasia, dysphasia, we don't know. If it is aphasia or dysphasia, it is cortical. Then convulsion goes in favor of a cortical. Aphasia, dysphasia goes in favor of a cortical. Apraxias, agnosias goes in favor of a cortical. Speech disorders like dysphasia will go in favor of a cortical. Let us see an examination whether he had really dysphasia or dysarthria. At this point, it is little difficult to diagnose whether it is internal capsule or motor cerebral cortex. Let us see on examination what we can come to the conclusion. And involving human facial palsy according to history, because facial deviation is there towards the left side and upper part of the face is not involved. So, right side hemiplegia, right side human palsy, cerebrovascular accident, embolic probably, either capsule or cortex. So, this is how you analyze the history, students. Now, coming to the general examination of the patient. Is conscious and oriented, is well built and nourished, height is 170 centimeters, weight is 94 kg, BMI is 32, no pallor, icterus, clubbing, lymphadenopathy. He has edema on the right lower limb, probably because of a dependent edema. I will demonstrate the edema. So, students, I will demonstrate the edema. You get unilateral edema in hemiplegia described in the books, students, and here also he is having edema, students. You can make out it is pitting here, right side, okay, because he is not using the right limb properly. That is the reason, okay, why he is getting it. Pulse rate 94 beats per minute, regular, normal volume, normal character, no radial delay, no radiofemoral delay, all peripheral pulses are felt. Temperature normal. Blood pressure now is 140/90, respiratory rate 16 cycles per minute. JVP it is normal, not raised. Head-to-toe examination, you have to look for neurocutaneous markers in this patient, especially Sturge-Weber syndrome, cavernous angioma. In the fifth nerve distribution, you have to look because that can bleed in the brain producing hemorrhage. Other neurocutaneous markers like neurofibromatosis, tuberous sclerosis, Van Hippel-Lindau, those things you have to look in any CNS case. Then signs of atherosclerosis, there are no xanthelasma, no xanthomas, no arcus senalis is not present. Coming to the central nervous system examination, students, high mental function, patient is conscious, is a right-handed person, oriented to time, place and person. Intelligence is normal, appearance and behavior is normal, attention, serial subtraction of 3, 5, 7 from 100, it is normal. Memory, immediate memory, that is the digit span, 5 digits he can count forward, 3 digit backward, he can do that. The recent memory, what he had just half an hour back, the breakfast he told properly. Remote memory, he can remember his date of marriage and which school he studied. So, memory is intact, both immediate, recent and remote memory. Speech is important. I will speak to him, students, just listen how he speaks. ಹೆಸರೇ ನಿಮ್ಮದು?
ಪ್ರಕಾಶ್.
ಮಕ್ಕಳೆಷ್ಟಿದ್ದಾರೆ?
ಇಬ್ಬರು ಸರ್.
ಓಕೆ. ನೀವು ಮುಂಚೆ ಇದೇ ಥರ ಮಾತಾಡ್ತಾ ಇದ್ದೀರಾ? ಈಗ ವ್ಯತ್ಯಾಸ ಆಗಿದೆಯಾ ಮಾತಾಡೋದು?
ಸರ್ ಮುಂಚೆ ಚೆನ್ನಾಗಿ ಮಾತಾಡ್ತಾ ಇದ್ದೆ.
ಈಗ ಸ್ವಲ್ಪ ತೊದಲಿದೆ. ಓಕೆ. ಈಸ್ ಟೆಲ್ಲಿಂಗ್ ಯು ಆರ್ ಸ್ಪೀಕಿಂಗ್ ನಾರ್ಮಲಿ ಬಿಫೋರ್, ನೌ ದೇರ್ ಇಸ್ ಎ ಪ್ರಾಬ್ಲಮ್. ಇವನ್ ಯು ಕ್ಯಾನ್ ಮೇಕ್ ಔಟ್ ಸ್ಟೂಡೆಂಟ್ಸ್, ದೇರ್ ಇಸ್ ಎ slurring of the speech, there is a dysarthria, but he understand whatever I tell. ಈ ಕೈ ಮೇಲೆ ಕೆತ್ತಿ. So comprehension is normal and he is speaking, okay. So there is no motor aphasia and there is no sensory aphasia. The problem is a dysarthria because of the facial nerve weakness, probably is having a dysarthria, okay. So that is the problem with him. Now let me discuss little few points about the speech disturbance here, students, very important in stroke patients. What is dysarthria, what is dysphasia, what is dysphonia? Dysphonia is problem with the phonation. Dysarthria is articulation problem, whereas dysphasia or aphasia is a language problem. Dysarthria will be due to the brainstem nuclei, it may be due to the 7th nerve, 5th nerve, 12th nerve, there can be a dysarthria. Dysphasia or aphasia is disorder of language. What are the two types of aphasias a patient with stroke will develop? You have a motor aphasia, sensory aphasia, two main types, the other types I will tell later. Motor aphasia is also known as Broca's aphasia, expressive aphasia, non-fluent aphasia. The problem is in the area number 44. Here it is also known as telegraphic speech, they will produce only little words. And prosody will be lost. What is prosody? When you speak, no, whenever you become angry, you will speak one type. Whenever you become sorrow, you will speak in a different pitch. The different pitch will be lost here. Prosody will be lost here in a Broca's aphasia. Then you have area number 22, sensory aphasia, also known as the receptive aphasia, fluent aphasia. Here they will use neologisms, the word which is not given in any dictionary of the any world. and they'll use paraphasias. Paraphasias, there are two types, literal and verbal paraphasia. Literal paraphasia means only single letter they will replace, cat, mat, rat, like that. Verbal paraphasia is entirely different. Book they will use, pen, pencil, like that, paraphasias. Then conduction aphasia, in between a motor and sensory, if there is any connection is problem, conduction aphasia. Here the only problem is repetition will be a problem in conduction aphasia. They will speak, they will understand, but repetition is the only problem. Repetition means you will ask the patient to say elephant, ELEPHANT, repeat, they won't be able to repeat it. Then there are other two types, transcortical motor, transcortical sensory aphasia. Transcortical motor behaves like a motor aphasia except the repetition will be normal. Transcortical sensory behaves like a sensory aphasia except the repetition will be normal. Due to the association areas, the connection will be lost from the motor area to the surrounding areas. That is why you will get transcortical motor and transcortical sensory aphasia where repetition will be normal. This is about the speech disturbance which you should do in any stroke patient. Then no delusion or hallucination, visuospatial defect is not there, okay. And other two things which you have to know about the higher mental function in stroke patient is agnosia and apraxias. Agnosia is difficult to recognize the sensory stimulus even though it is perceived. The meaning of the sensory stimulus they couldn't recognize even though it is perceived. It could be olfactory agnosia, auditory agnosia, visuospatial agnosia, or autoposognosia. Autoposognosia means their finger only they won't be recognized. Finger agnosia is autoposognosia. They won't recognize that is their middle finger, index finger, like that. Then simultaneognosia. If you take them to a forest, they will see only tree but not the forest. Other impulse they cannot interpret. They cannot scan it. Prosopagnosia, phase. They won't be able to recognize the phase. Stereognosis. They couldn't able to recognize the objects. These are all types of agnosias. Agnosia is a feature of a non-dominant cortex. If MCA is involved, I will discuss when I discuss. Then anasognosia. Anasognosia is they like agnosia, but they will deny it. They are able to realize that they are having the defect, that is anasognosia. Then apraxia. So what is apraxia? Apraxia is the inability to do a command even though if there is a no motor weakness or sensory deficit in the arm, in the whichever limb you are testing it. That is apraxia. Apraxias again a feature of stroke, especially the cortex, which I will discuss when I discuss the clinical feature of different areas. There can be a lid apraxia, they won't be able to elevate the lid even though there is no weakness. Gaze apraxia, they want to do a gaze in the eyes, lateral gaze, medial gaze, even though the nuclei is normal, cranial nuclei. Gaze apraxia, lid apraxia. Gait apraxia, no weakness but they won't be able to walk properly. Gait apraxia. Sympathetic apraxia, if there is a right hemiplegia, the left which is normal, that they won't be able to use it even if there is no weakness. That is sympathetic apraxia. Then if you have a non-dominant lobe, in a right-handed person, the left is a dominant. In a left-handed person, again left only, most of the times it is dominant. In a dominant lobe, if the parietal lobe is involved, they will have two apraxias, dressing apraxia, constructional apraxia. Dressing apraxia, they won't be able to don the cloth. Constructional, you give some diagrams, you won't be able to write it. Then ideational, ideomotor apraxia, if you get a dominant parietal lobe. Ideomotor is the complex motor activity, salute, say bye, those kind of things you won't be able to do it. Ideational apraxia is the single component they will do, but as a whole they won't do. For example, if you give a matchbox, tell them to light the matchstick, they won't be able to do. Instead of that, if you tell, open the matchbox, remove the stick, rub it, like individual components they will understand, but not the idea of the whole act. That is ideational apraxia. Then buccofacial apraxia, they won't be able to do whistling or put a tongue out. So apraxia, agnosia, aphasia, very special features of higher mental function in a stroke patient which you have to examine and discuss. So in his mini mental status examination is 30 by 30, okay, he is not having any apraxia or agnosia. Coming to the cranial nerve examination, olfactory nerve it is normal, optic nerve, visual acuity is normal, field of vision is normal, color vision and optic fundus is normal. Second nerve examination is normal. Third, fourth and sixth cranial nerve, he moves the eyeball movements in all the direction, it is normal, there is no ptosis, no proptosis, there is no squint and no diplopia. Third, fourth and sixth cranial examination is normal. Third nerve paralysis, okay, with the hemiplegia is a feature of posterior circulation stroke students, especially midbrain syndromes, which I will discuss when I discuss one more case, thalamic infarction, all the posterior circulation, anatomy, blood circulation, DD analysis in detail. Let us not confuse now today with this anterior circulation stroke, which is having a hemiplegia of the right hand and right lower limb. There is no nystagmus, there is no Horner syndrome, okay. Pupil, the size is 3 mm, shape is round bilaterally, and pupillary reaction is normal and equal in both the sides. Both direct and concentric reflex is normal. Accommodation reflex is also normal bilaterally, and Marcus Gunn pupil, relative afferent pupillary defect is not there. Fifth nerve examination, sensory examination students, pain and temperature and general sensation over the face, it is normal here, it is not affected. Motor part, the muscles of mastication is normal, okay, the temporalis, masseter, pterygoids are normal. Reflexes of the fifth nerve, corneal, conjunctival is normal, and there is a jaw jack reflex is present. Seventh nerve examination is important. Let me examine the seventh nerve in him, okay. So students, seventh nerve examination is very important here, okay. Quickly I will examine all the muscles supplied by the seventh nerve, okay. Then bell nodi mele. So you can see the furrows here. Kan muchi tight again. You can close the eyes, both the eyes. Okay. Hal torsing he might yeah, now it is normal. The wife told the mouth deviated to left side when he had a weakness 2 years back, but now it is normal. Okay, ingit kode. Buccinator is normal. Okay, saku. Right. Nimage fees load ek barta? What is it? Yeah. So orbicularis oris, buccinator, orbicularis oculi, frontal belly of occipitofrontalis, everything is normal. Facial nerve has improved student, whatever he had 2 years back, it has improved now. Okay. Facial nerve examination is very important because ipsilateral seventh nerve palsy, ipsilateral hemiplegia you will get, okay, whenever UMN part is affected like cortex, internal capsule. Okay. Seventh nerve examination is important. So eighth nerve examination, Rinne's AC is better than BC. Weber's is in the middle, it is lateralized equally to both the sides. Absolute bone conduction same as the examiner, so it is not abnormal. And 9th and 10th nerve examination, HCV also there is no nasal regurgitation and there is no nasal twang or any oceans of the voice. Uvula is central, gag reflex is normal, palatal reflex is also normal. It is not affected 9th and 10th here. 11th nerve examination, turning of the neck side to side is normal, shrugging of shoulder is also normal. 12th nerve examination, there is no fasciculation of fibrillation. Students, no deviation of the tongue, strength of the tongue is normal in all the direction, no muscles is affected. Okay, only 7th nerve examination is important here in anterior circulation stroke. The other cranial nerves, lower cranial nerves are important in posterior circulation stroke, which I will discuss in a thalamic infarction patient when I will discuss. Coming to the motor system examination students, okay, the bulk of the muscle, the arm right side it is 31 centimeter, left side 33 centimeter, forearm 28 centimeters, left side 29 centimeters. So there is slight wasting on the right side because probably is not using the right upper limb as much as the left. Normally if a right hand person, right side should be, size should be more slightly 1 centimeter or 2 centimeters. But here right side is less 31, left side is 33, forearm is 28. So there is a wasting, probably is not using the right side as much as this left side. Thigh right side is 44, left side is 44, calf right side is 55, left side is 56. Let me examine the tone of the muscle. The tone of the muscle, you have to flex and extend. Here there is hypertonia, spasticity. While extending, you have to look for the biceps muscles, okay. This is how you look for the tone. And here also, you have to look. Left side it is normal. There is a normal, but right side there is definitely, and you have to do 4-5 times fast because it is velocity dependent. Spasticity is velocity dependent. This is how you look for the tone in the upper limb. Lower limb, there are two methods to look for tone. Lower limb, you have to look, there are two methods to look for the tone in the lower limb. You have to just move the leg like this. If it is hypotonia, the range of movement will be more. You have to move the leg like this. This is one method. The other method is you have to lift the leg If normal means it comes along the ground like that, okay, that is the left side. This right side, here also it is coming normally along the ground. If it is very severe spasticity, when I lift the leg, the whole leg will lift like this instead of dragging along the bed. Okay, students. So he has a hypertonia, spasticity and rigidity. What is the difference? Spasticity is corticospinal tract involvement. Rigidity is extrapyramidal tract involvement. Corticospinal tract anti-gravity muscles will be having a more tone, like a flexor group of muscles. Okay, agonist. Whereas in rigidity, both agonist and antagonist will be having a hypertonia. In rigidity, there are two types: lead pipe rigidity and cogwheel rigidity. Lead pipe, throughout the movement there will be a resistance. Cogwheel is intermittent resistance you will feel. Spasticity is velocity dependent. If you do 4-5 times fast, then you will appreciate better spasticity. Okay? And spasticity will be associated with the plantar extensor. Rigidity won't be associated with plantar extensors. Okay? Here, right upper limb there is a spasticity. Okay? Lower limb there is tone is normal only. Okay? Right upper limb there is class-wise spasticity, which indicates a corticospinal tract involvement. Let me quickly go through the power of his examination in this patient. Okay, students, now let me examine the power in the upper limb, the shoulder abduction and adduction. ನಾನು ಹೇಳಿದಾಗ ಕೈನ ಈ ಥರ ಮಾಡಬೇಕು. ಓಕೆ, ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. ಸಿ ಸ್ಟೂಡೆಂಟ್ಸ್, ಲೆಫ್ಟ್ ಸೈಡ್ ಈಸ್ ಮೂವಿಂಗ್ ಇಟ್, ರೈಟ್ ಸೈಡ್ ಈಸ್ ನಾಟ್ ಮೂವಿಂಗ್ ಇಟ್ ಬಿಕಾಸ್ ದೆರ್ ಇಸ್ ಎ ರೈಟ್ ಸೈಡ್ ವೀಕ್ನೆಸ್ ಇಸ್ ದೇರ್. ಬಟ್ ರೈಟ್ ಸೈಡ್ ಯು ಕ್ಯಾನ್ ಲಿಫ್ಟ್ ಇಟ್ ಅಗೇನ್ಸ್ಟ್ ದ ಗ್ರಾವಿಟಿ. ಕೈ ಹೀಗೆ ಮಾಡಿ ರೈಟ್ ಸೈಡ್. ಇಟ್ ಈಸ್ 3 ಬಟ್ 4 ಮೈನಸ್ ರೈಟ್ ಸೈಡ್ ಅಬ್ಡಕ್ಷನ್. ಲೆಟ್ ಮೀ ಚೆಕ್ ಫಾರ್ ದ ಅಡಕ್ಷನ್. ಕೈ ಹೀಗಿರುತ್ತಲ್ಲ, ಹಿಂಗೆ ಒಳಗೆ ತರಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ತೊಗೊಮನಿ ಒಳಗೆ ತೊಗೊಮನಿ. ಈಸ್ ಬ್ರಿಂಗಿಂಗ್ ದ ಲೆಫ್ಟ್ ಸೈಡ್, ರೈಟ್ ಸೈಡ್ ಈಸ್ ಅನೇಬಲ್ ಟು bring it, that is adduction. Shoulder abduction is done by the initial 15 degree by supraspinatus, later by deltoid, later by trapezius. The shoulder abduction. Shoulder adduction is done by pectoralis major and latissimus dorsi. Shoulder adduction. Okay? Shoulder flexion and extension. ಕೈ ನಾನು ಹೇಳಿದಾಗ ಹೀಗೆ ಮಡ್ಚ್ಕೋಬೇಕು. ಮಡ್ಚ್ಕೊಳ್ಳಿ. He is having difficulty, students. You can make out. Definitely there is a weakness. ಸಾಕು ಬಿಡಿ, ಸಾಕು. ಈ ಕೈ ಇದೆಯಲ್ಲ, ನಾನು ಹೇಳಿದಾಗ ಈ ಥರ ಮಡ್ಚ್ಕೋಬೇಕು. ಕೈ ಮಡ್ಚ್ಕೊಳ್ಳಿ, ಹಂಗೆ ಈ ಶೋಲ್ಡರ್ ಮುಟ್ಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಮಡ್ಚ್ಕೊಳ್ಳಿ. You can do this, student, shoulder flexion done by anterior fibers of deltoid and pectoralis major. Okay, next is shoulder extension. ಕೈ ಹೀಗಿದೆಯಲ್ಲ, ಇದನ್ನ ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಮಾಡಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಈಸ್ ಹ್ಯಾವಿಂಗ್ ಡಿಫಿಕಲ್ಟಿ, ಸ್ಟೂಡೆಂಟ್. ಸಿ ಈಸ್ ನಾಟ್ ಡೂಯಿಂಗ್ ಇಟ್. ಕೈ ಹೀಗಿದೆಯಲ್ಲ, ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಮಾಡಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. You can do it. Shoulder extension is done by posterior fibers of deltoid and latissimus dorsi. Shoulder extension. Okay? This shoulder muscles. Next, elbow joint flexion and extension. ಕೈನ ಹೀಗೆ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಮಾಡಿ. There is a weakness, students. ಕೈನ ಹೀಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಮಾಡಿ. Shoulder extension. Both are weak, students, but you can do against the gravity. ಕೈ ಹೀಗೆ ಮಾಡಿ, ಹೀಗೆ ಮಾಡಿ. ಕೈ ಮಡಚ್ಕೊಂಡು ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು. ಮಾಡಿ. ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಯು ಕ್ಯಾನ್ ಡೂ ಇಟ್ ಅಗೇನ್ಸ್ಟ್ ದ ಗ್ರಾವಿಟಿ. ಈ ಕೈ ಇದೆಯಲ್ಲ, ಈಗ ಮಡ್ಚ್ಕೋಬೇಕು. ಕೈ ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಯು ಕ್ಯಾನ್ ಡೂ ಇಟ್. ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಯು ಕ್ಯಾನ್ ಡೂ ಇಟ್. ಸೊ ರೈಟ್ ಸೈಡ್ ಫ್ಲೆಕ್ಷನ್ ಎಕ್ಸ್ಟೆನ್ಷನ್ ಇಸ್ ಆಲ್ಸೋ ವೀಕ್. ಓಕೆ, ರೈಟ್. ಲೆಟ್ ಮಿ ಚೆಕ್ ದ ಹ್ಯಾಂಡ್ ಗ್ರಿಪ್. ಟೈಟಾಗಿ ಬಿಗಿಯಾಗಿ ಇಟ್ಕೊಳ್ಳಿ. See, students, there is hand grip is weak on the right side. Hand grip is weak on the right side. Let me check on the left side. Tightly itkoli. It is normal. It is normal, students. See, power is normal on the left side, but the right side, tightly itkoli, hand grip is weak. Okay. Now, students, now let us examine the power in the lower limb. Okay. ಈ ಕಾಲು ಇದೆಯಲ್ಲ, ಇದು ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಅಗಲ ಮಾಡಬೇಕು. ಓಕೆ, ಮಾಡಿ. You can do left side. See, students, right side there is a weakness. Shoulder, the hip abduction. Saku. Hip abduction is done by gluteus medius, minimus and tensor fascia lata. Next, hip adduction. ಈ ಕಾಲು ಹೀಗಿದೆಯಲ್ಲ, ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಒಳಗೆ ತರಬೇಕು. ತಗೊಂಬನ್ನಿ. See, students, you can bring the left side. Right side is not bringing it. Once more I demonstrate. ತಗೊಂಬನ್ನಿ ಒಳಗೆ. You can bring the left side. Right side is unable to do it. So, students, hip adduction. ಕಾಲು ಒಳಗಡೆ ತಗೊಳ್ಳಿ. You can do left side but not right side. Hip adduction is done by adductor magnus, adductor brevis, adductor group of muscles. Hip flexion, ಇದು ಇಲ್ಲಿ ತಗೊಂಬನ್ನಿ. Very good, very good, very good. You can do it but not to the normal. Let me see on this side. ಈ ಕಾಲು ಮಡ್ಚ್ಕೊಳ್ಳಿ, ಅಲ್ಲಿಗೆ ಮಡ್ಚ್ಕೊಳ್ಳಿ. You can do it. Okay, hip flexion. Hip flexion is done by iliopsoas. Hip extension is also weak in him, done by gluteus maximus. I don't want to trouble him again, making him prone. Let me do knee extension, knee flexion. ಈ ಕಾಲನ್ನ ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಮಾಡಿ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ದಿಸ್ knee extension, right side. ಇದು ಮಾಡಿ ಸ್ಟ್ರೈಟ್. You can do left side normally. That is done by quadricep group of muscles, knee extension. Knee flexion ideally should do with the prone position, make the patient prone and flex the knee, okay? Or else even you can test like this. ನಾನು ಹೇಳಿದಾಗ ಕಾಲನ್ನ ಹಿಂಗೆ ಒಳಗಡೆ ತೊಗೋಬೇಕು. ತಗೊಳ್ಳಿ, ಒಳಗಡೆ ತಗೊಳ್ಳಿ, ಬಿಡಿ. ಇದು ಕಾಲು ತೊಗೊಳ್ಳಿ, ಒಳಗಡೆ ತೊಗೊಳ್ಳಿ. I can do left side normally. Okay. Next is ankle, dorsiflexion, plantar flexion, inversion, eversion. ನಾನು ಹೇಳಿದಾಗ ಪಾದ ನೀವು ಮೇಲ್ ಮಾಡಬೇಕು. ಮಾಡಿ. ದರ್ ಇಸ್ ಅ ವೀಕ್ನೆಸ್ ಆಫ್ dorsiflexion done by tibialis anterior. ಇದನ್ನು ಪಾದ ಮೇಲೆ ಮಾಡಿ. ಯು ಕ್ಯಾನ್ ಡೂ ದಿಸ್ ನಾರ್ಮಲಿ. ಯು ಕ್ಯಾನ್ ಡೂ ದಿಸ್, ಓಕೆ. ದೆನ್ ಪ್ಲಾಂಟರ್ ಫ್ಲೆಕ್ಷನ್, ಪಾದನ ಹಿಂಗೆ ಕೆಳಗೆ ತರಬೇಕು. ಕೆಳಗೆ ತೊಗೊಂಬನಿ. ದಿಸ್ ಆಲ್ಸೋ ವೀಕ್ ಪ್ಲಾಂಟರ್ ಫ್ಲೆಕ್ಷನ್ ಡನ್ ಬೈ tibialis posterior. ಇದು ತೊಗೊಂಬನಿ ಕೆಳಗಡೆಗೆ. You can do this left side. So there is a dorsiflexion, plantar flexion is weak on the ankle. Now let me do inversion, eversion. ನಾನು ಹೇಳಿದಾಗ ಈ ಪಾದ ಇದೆಯಲ್ಲ ಹಿಂಗೆ ತರಬೇಕು ಮತ್ತು ಹೀಗೆ ತರಬೇಕು. ಇವಾಗ ಈ ಸೈಡ್ ಹೀಗೆ ಮಾಡಿ, ಇದನ್ನು ಹಿಂಗೆ ಮೇಲೆ ಮಾಡ್ಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಮಾಡಿ. ಈಸ್ ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ಇನ್ವರ್ಷನ್. ಲೆಟ್ ಮಿ ಡೂ ದಿಸ್ ಸೈಡ್. ಇದು ಮಾಡಿ. Eversion, apply the pressure on the lateral part of the foot, ask him to do like this. ಈ ಪಾದ ಇದೆಯಲ್ಲ ಹಿಂಗೆ ಮಾಡಿ. ಮಾಡಿ ಆಗಲ್ವಾ? ಆಗಲ್ಲ. ಈಸ್ ಅನೇಬಲ್ ಟು ಡೂ ದ್ಯಾಟ್. ಇದನ್ನು ಮಾಡಿ. ಇದನ್ನು ಮಾಡ್ಬೋದು. ಓಕೆ. ಲೆಫ್ಟ್ ಸೈಡ್ is able to do eversion but not on the right side. Okay. So there is a weakness on the right side: dorsiflexion, plantar flexion, inversion, eversion, knee flexion, extension. Knee flexion is done by hamstring group of muscles. Biceps femoris, semimembranosus, semitendinosus. Knee extension is done by quadricep group of muscles. Okay, right. So overall, there is a weakness on the right upper limb and lower limb. It is between 4- to 4+ in the right side, upper limb and lower limb. Okay, students. Now, and hand grip is weak on the right side. Coming to the coordination. Coordination test, finger nose test is normal. Finger to finger nose test is also normal. No rebounds phenomena. No pause pointing is there. No dysradicokinesia. Heel knee test is able to do in the lower limb, so there is no cerebellar signs. Other cerebellar signs like nystagmus, pendulum knee jerk is not there. Okay, and he can do tandem walking. Coming to the reflexes, superficial reflexes, corneal reflex is intact, conjunctival reflex is intact, and gag reflex is normal. Abdominal reflex, because he is obese, it is absent bilaterally. I will demonstrate the abdominal reflex. And one more important reflex, superficial plantar reflex. Both I will demonstrate. So students, I will demonstrate the abdominal reflex. So what do you expect, students? Abdominal reflex on the right side here. Right side hemiplegia, corticospinal tract involvement. Abdominal reflex should be absent right side. But here left side is also absent. Probably is a pendulous abdomen, obese. That is the reason. And you have to do a cremasteric reflex because this male I don't want to expose. Okay. Even cremasteric reflex will be absent same side of the corticospinal tract involvement. Abdominal and cremasteric both are the same significance. Both will be absent. Abdominal and cremasteric reflex. Okay. The iliopingular nerve is the afferent, genital branch of genitofemoral nerve is the efferent for cremasteric reflex. Let me elicit the plantar reflex. So students, the hard side in CNS, the plantar reflex, now I am going to elicit, just see it. So right side. See students, extensor, classic extensor. Once more I will elicit. See the dorsiflexion of the metatarsophalangeal joint, fanning of the other toes. Let me do on the left side. It is neither coming flexor or extensor left side, but right side it is coming classic extensor. Once more I want to demonstrate. If you do 2-3 times, you may not get sometimes. That is the reason. Now let us come to the deep tendon reflexes, students. Very important deep tendon reflexes. I will demonstrate all the important deep tendon reflexes. Okay, students, biceps, triceps and brachioradialis I will elicit. Biceps right side. See students, it is brisk. You can make out the biceps reflex so brisk. Okay, classic. Left side it is normal. I want to show the triceps on right side. See students, so brisk. I'll expose and show you again. See the reflex. See students, the triceps reflex. It is exaggerated. Let me do the brachioradialis. See, exaggerated students. See the reflex here. Exaggerated. So classic. Left side it is normal. Okay. Let me do the reflexes in the lower limb now. Students, let me elicit the knee reflex, ankle jerk, and if exaggerated, whether I can elicit clonus, let us see. So students, knee jerk. See students, it is exaggerated. I'll try to elicit clonus, whether I'll get it or not. Left side, see, hardly I am able to get it. Left side. Okay. Now ankle jerk. First let me elicit the clonus here in the knee jerk. I'll try to elicit the patellar clonus. No patellar clonus students. Okay, let me elicit ankle jerk. See, it is exaggerated ankle jerk. You can make out. I'll try to elicit the clonus. Left side, let me see the ankle jerk. It is present. So students, I'll demonstrate how to look for ankle clonus. Hold here, give a sudden jerk. So he is having a clonus. I'll do again. So there is an ankle clonus students. Once more I'll try to demonstrate. See, a classic ankle clonus. Left side, it is not there. Right side, once more I'll do. So students, let us go to the examination of the sensory system. Superficial sensation, pain, temperature, touch is intact on right side. Only there is a motor weakness, but sensory system, superficial sensation, pain, temperature, touch is intact on the right side, and normal also on the left side. The deep sensation, position sensation, joint sensation, vibration sensation is intact on the right side and also intact on the left side. And Romberg sign is negative. The cortical sensation is very important in him. The cortical sensation is normal. Okay, the tactile localization, 2-point discrimination, stereognosis, graphesthesia, everything is intact. Let me do quickly the cortical sensation. So tactile localization. Is localizing. Tactile localization is normal. So let me do graphesthesia. Number ಬರೀತೀನಿ ಎಷ್ಟು ಅಂತ ಹೇಳಬೇಕು. ಎಷ್ಟಿದು?
1.
ಇದು?
3 ಸರ್.
ಕರೆಕ್ಟ್.
3 ಸರ್.
ಇದು?
ಸರ್ 0.
ಇದು?
ಸರ್ ಗೊತ್ತಾಗಿಲ್ಲ.
ಗೊತ್ತಾಗಿಲ್ಲ ಅಲ್ಲ? ಓಕೆ. ಇದೆಷ್ಟು?
1.
ಯಾ. ಸೊ ಕಾರ್ಟಿಕಲ್ ಸೆನ್ಸೇಷನ್ ಇಸ್ ನಾರ್ಮಲ್ ಇನ್ ನಿಮ್. ಓಕೆ. ನೌ ಲೆಟ್ ಮಿ ಡು ಸ್ಟೀರಿಯೋಗ್ನೋಸಿಸ್. ಕಣ್ಣು ಮುಚ್ಕೊಳ್ಳಿ. ನಿಮ್ಮ ಕೈಗೆ ಕೆಲವು ವಸ್ತು ಕೊಡ್ತೀನಿ, ಏನು ಅಂತ ಹೇಳಬೇಕು.
ಆಯ್ತು ಸರ್.
ಏನಿದು?
ಸರ್ ಬಿಗ್ ಕೈ.
ಆ ಕೈಯಲ್ಲಿ ಮುಟ್ಬಾರ್ದು, ಬಲಗೈಯಲ್ಲಿ ಮುಟ್ಟಿ ಹೇಳಬೇಕು.
ಆಯ್ತು ಸರ್. ಆಯ್ತು ಸರ್.
ಏನಿದು?
ಸರ್ ಪೆನ್ನು.
So you can tell pen. Okay. So stereognosis is also normal. This test is very important, students. So cortical sensation is normal in him. Tactile localization, 2-point discrimination, stereognosis, graphesthesia is intact. The gait I will show here is circumduction gait. At the end of the discussion I will show that. Okay. And the skull and spine is normal. No signs of meningeal irritation. Autonomic nervous system is normal. Other system, cardiovascular, there is no murmur. Especially you have to look for a carotid bruit in this case. He is not having carotid bruit. At the upper level of carotid bifurcation, you have to look for a carotid bruit in this patient. Okay? There is no carotid bruit. Respiratory examination is normal. GAT is normal. Okay? So let me examine the gait in him and then I will discuss the diagnosis in him and the theory part of the cerebrovascular accident. ನಡೀರಿ ವಾಕ್ ಮಾಡಿ. ಸ್ಟೂಡೆಂಟ್ಸ್, ಯು ಕ್ಯಾನ್ ಸಿ ದ ಸರ್ಕಮ್ಡಕ್ಷನ್ ಗೈಡ್ ಈಸ್ ಜಸ್ಟ್ ಟೇಕಿಂಗ್ ಅವೇ outside the leg and is dragging it the right leg. Circumduction gait on the right leg, students. So students, what are the positive findings we got in him? So there is a diffuse wasting on the right side, right upper limb. There is the nutrition, it is a wasting is there. Tone, there is a class-wise spasticity on the right upper limb, but lower limb the tone is normal. The power, there is a 4 minus to 4 plus weakness in the right upper limb and lower limb. There is a motor weakness is there. Deep tendon reflexes are exaggerated and there is an ankle clonus. Plantar is extensor are on the right side. So you got all the UMN signs on the right side. So right sided hemiparesis, facial nerve improved. The wife told at that time facial nerve was affected. And what is the etiology? Vascular, sudden in onset. And it improved. Probably that is why I want to put a embolic as the etiology. Where is the localization? Whether it is an internal capsule or cortex. There is no aphasia, only dysarthria is there. And probably what he had a headache and convulsion at that time could be due to hypertensive encephalopathy is one of the cause. Probably he stopped the medicines for 20 days at that time. That may be the cause for his hypertensive encephalopathy, headache and altered level of consciousness and convulsion. So I want to localize in the internal capsule only this patient. Okay, the CVA, right sided hemiparesis now. Okay, right sided human facial palsy at that time. Embolic etiology in the MCA territory. Okay, internal capsule. Okay, right. So what the investigation showed in him? Just I want to read the MRI finding what it showed on him. Students, the MRI finding done on 2019 6th of January, acute infarct in the corona radiata on the left side of the brain. Okay, so there is no hemorrhagic transformation. So this is the MRI report which is done on the 2019. So probably that is the reason. And whatever he had a headache, altered behavior due to hypertensive encephalopathy at that time. So you can explain by that. And one more thing, he is a stroke in young patient because he is 40-year-old. Okay, they have done homocysteine level, students. It is 23 micromoles per liter. Homocysteine is elevated. Probably that is the reason for his hypercoagulable state which has produced the stroke in him. So students, coming to the what are the etiology of ischemic stroke? Ischemic stroke is both a embolic stroke and a thrombotic stroke. That is ischemic stroke. Hemorrhagic stroke is due to the hemorrhage. So it could be due to a thrombosis. The thrombosis can occur in a large vessel thrombosis, okay, or due to a dehydration it can occur, or it could occur due to a lacunar thrombosis, the small vessel thrombosis. These are the three causes of thrombosis. Coming to the embolism, it could be artery to artery. The artery to artery embolism from carotid bifurcation, if there is a thrombus, it can throw the embolism. Or a aortic arch, if there is any thrombus, that can throw the embolism. Aortic arch or a carotid artery, or due to a arterial dissection, it can throw the embolism. Then the cardiac cause of embolism, mitral stenosis with atrial fibrillation, bacterial endocarditis, myocardial infarction, dilated cardiomyopathy, valvular heart lesions can produce a embolism from the heart. So embolism can occur from the heart or from the artery to artery. Two embolisms. Artery to artery is the commonest. Then from the cardia also embolism can be thrown to the arteries. Then the paradoxical embolism, you may get in patent foramen oval, atrial septal defect and atrial septal aneurysms. You may get a paradoxical embolism. Then because of the another common cause of the ischemic stroke is due to drug illicit, especially younger age groups, cocaine and amphetamine. Then in a mitral stenosis, spontaneous echo contrast in the left atria can produce embolism. These are some of the common causes of ischemic stroke. Coming to the uncommon cause of ischemic stroke, you have a hypercoagulable states, protein C, protein S deficiency, prothrombin G mutation, whereas 20-21-0 mutation can occur. Factor V little mutation can produce a hypercoagulable state. Inflammatory bowel disease, dysproteinemias, nephrotic syndrome, OC pills usage can produce hypercoagulable state. Then hemorrhagical disorders like thalassemia, sickle cell, polycythemia vera can produce the hypercoagulable state. Then thrombotic thrombocytopenic purpura, disseminated intravascular coagulation can produce a hypercoagulable state. Then you have vasculitis. Vasculitis could be infective due to tuberculosis, meningitis, syphilis, fungal, parasitic bacteria. Or it could be due to vaginous granulomatosis, polyarteritis nodosa, Takayasu disease, aortic arch syndrome, Takayasu also known as giant cell arteritis, can produce a stroke because of vasculitis. Then you have a non-inflammatory vasculopathy known as a reversible vasoconstriction syndrome, Fabry's disease, then angiocentric lymphoma, non-inflammatory vasculitis. Then rare cardiac diseases which can produce ischemic stroke is mitral valvular calcification, non-bacterial thrombotic, non-bacterial endocarditis, NBTE, Liebman sac endocarditis, or any other cardiac tumor, atrial myxomas can produce ischemic stroke, rare causes. Then fibromuscular dysplasia can produce ischemic stroke, again a rare cause. Migraine patients can have hemiplegia, which is reversible. Eclampsia can produce ischemic stroke. Then after subarachnoid hemorrhage, the blood vessels can undergo vasospasm because CSF covers the blood vessels. Nutrition will be a problem to blood vessels that can produce vasospasm and ischemic stroke. So these are some of the rare causes of the ischemic stroke, a common cause of ischemic stroke. So you should know about that. Then come to the clinical feature. Suppose if depending upon the artery, if it is involved, how the clinical manifestation will manifest. Before that, you should know the blood supply of the brain. Students, mainly it is anterior circulation and posterior circulation, which I will explain in the green screen recording, the anterior circulation and posterior circulation. So, blood circulation, mainly anterior circulation and posterior circulation, which I will explain later in the theory part again. Okay. Anterior circulation, students, you have internal carotid artery, which gives middle cerebral artery and anterior cerebral artery. This is anterior circulation. The posterior circulation is two vertebral artery will join together to form a basilar artery that divides into a posterior cerebral artery. Vertebral artery will give posterior inferior cerebellar artery, then superior middle and inferior lateral medullary artery, anterior and posterior spinal arteries. Basilar artery will give a paramedian branches, short circumferential branches, and a large circumferential branch which is nothing but a superior cerebellar artery and anterior inferior cerebellar artery. So mainly supplying the pons, cerebellum, the basilar artery. Vertebral artery supplies a cerebellum, lateral part of the medulla. It supplies. Then you have posterior cerebral artery. The basilar artery divides into two posterior cerebral artery. The P1 segment before the posterior communicating artery, that is P1 segment. Then the P2 segment. P2 segment supplies the cortex, occipital cortex and temporal lobe. Whereas the P1 segments just before the posterior communicating artery supplies the thalamus and midbrain. That's all. Midbrain, thalamus, pons, medulla. Again, I discuss in detail and in depth the posterior circulation stroke when I discuss a case of thalamic infarction, students, and all the medullary syndromes, brainstem syndromes I will discuss in detail. I don't want to confuse you at this point with the anterior circulation stroke which this patient is having, the right hemiplegia due to a MCA territory. Suppose if MCA territory, so this is the blood circulation of the brain, okay, and then the circle of Willis. Circle of Willis, you have a two vertebral artery joined together to form a basilar artery, divides into two posterior cerebral artery. Then you have a posterior communicating artery which communicates with the internal carotid artery. Internal carotid artery gives rise to a two anterior cerebral artery, both are communicated with the anterior communicating artery, and internal carotid artery also gives the middle cerebral artery. So that is circle of Willis. In the cerebral cortex, the lateral part of the cortex is supplied by middle cerebral artery. Only the medial 2 centimeters is by anterior cerebral artery. Then the medial part of the lobe is supplied by anterior cerebral artery. The occipital lobe and the inferior part of the temporal lobe is supplied by posterior cerebral artery. This is the blood circulation of the cerebral cortex. Circle of Willis. Then blood supply of internal capsule. You have an anterior limb, genu, posterior limb. The superior half is supplied by middle cerebral artery lenticulostriate branch. The inferior part anterior limb is supplied by Hebnur artery of an anterior cerebral artery. This recurrent branch of Hebnur artery, if it is involved, there is faciobrachial weakness. The genu is supplied by posterior communicating artery, whereas the posterior limb is supplied by anterior choroidal artery of an internal carotid artery, the inferior part. This is a blood circulation of internal capsule, again which I will discuss with a diagram when I tell the theory part later. So you should know about the blood circulation. Now depending upon the clinical features, which artery, if MCA is involved, what the patient will have, if ACA is involved, what the patient will have. If middle cerebral artery is involved, suppose if a right middle cerebral artery is involved, patient will have the left contralateral motor weakness like in him. In contralateral sensory abnormalities like a cortical sensation, 2-point discrimination, tactile localization, stereognosis, graphesthesia will be affected on the contralateral part because the motor cortex will be involved and sensory cortex will be involved. Broca's aphasia, if the dominant lobe is involved. In a right-handed person, the dominant lobe is the left lobe. So if a dominant lobe, left lobe, if the superior division is involved, patient will have a motor aphasia. If the inferior division is involved, he will have a Wernicke's aphasia. And if a parietal operculum is involved, he will have a conduction aphasia. Then dominant parieto-occipital lobe, if it is involved due to MCA territory, he will have RAF syndrome, RAAF, also known as Justman syndrome. That is right to left confusion, finger agnosia, acalculia and alexia. RAFF, right to left confusion, acalculia, alexia, F is finger agnosia, dominant parieto-occipital lobe. If a non-dominant parietal lobe is involved, patient will have, as I discussed in higher mental function, anosognosia, epractognosia, dressing apraxia, constructional apraxia. Constructional apraxia is you give a matrix, ask him to make a square or ask him to write a square or circle, he won't be able to do that. Dressing, he cannot don it. Then agnosia I discussed in higher mental function. So, and they'll have hemi-neglect, the left side of the visuospatial neglect, hemi-neglect they'll have if the non-dominant lobe is involved. And one more clinical feature is, for example, if in a right-sided hemiparesis, if the left MCA is involved, the eye will deviate towards the side of lesion, that is towards the left side. If left MCA is affected, the right normal cortex will force the eye towards the left side. That is due to a frontal contraversive eye field area affection in MCA territory infarction. These are all the clinical features what you will get if MCA is affected. MCA main trunk divides into superior and inferior division in the Rolandic fissure. If stem is affected, everything will be affected. Then hemianopia. If the inferior division which supplies the temporal lobe is affected, they will have superior quadrant anopia. If the superior division is affected, they will have inferior quadrant anopia because of the optic radiation affection. This is the MCA territory clinical features, students. Come to the anterior cerebral artery clinical features. Anterior cerebral artery, for example, if ipsilateral anterior cerebral artery is affected, contralateral there will be a weakness, predominantly leg compared to the arm because the body is represented upside down. If an unpaired anterior cerebral artery is involved, only one anterior cerebral artery from both the sides, they will have paraparesis. So same area wherever there is a weakness, they will have a cortical loss sensation will be lost. 2-point discrimination, stereognosis, that will be lost because of the sensory cortex which is involved supplied by the anterior cerebral artery. They will have a bladder involvement because you have paracentral lobule in the brain supplied by anterior cerebral artery. So there will be disinhibition, they will be having a social voiding of the urine, bladder disinhibition. Akinetic mutism and ebulia. Any person to move the action, initiation of the action is done by frontal lobe. If that is damaged, they will be just sitting quiet, that is known as ebulia. The severe form is known as akinetic mutism. For this, the location they don't know where is the problem, but anterior cerebral artery produces. But where is the brain, they are unable to localize where is the problem due to for akinetic mutism or ebulia. They can have a grasp reflex, sucking reflex and jejunal in the anterior cerebral artery occlusion due to a supplementary motor area affection. They can have a contralateral gait apraxia if ACA is involved. Left limb apraxia and tactile aphasia you may get if corpus callosum is involved due to the anterior cerebral artery. So left limb apraxia I told already what is apraxia. Tactile aphasia is nothing but like a stereognosis. You write some numbers, they won't be able to tell it. That is tactile aphasia. It is a feature of corpus callosum affection of the anterior cerebral artery. For anterior circulation, these two, but a posterior circulation involves midbrain syndromes, superior middle and inferior pontine syndromes, lateral middle and medullary syndromes, which all I will discuss detail when I discuss one more case students thalamic infarction, mainly for postgraduate studies, but this is both for undergraduates and postgraduates. So that is about the clinical feature, and one more thing you should know what about is lacunar stroke. Lacunar stroke is due to the deep penetrating branches of the arteries of a MCA, vertebral artery, basilar artery. The size will be around 30 to 300 micrometers, the blood vessels, due to lipohyalinosis. The size of the infarction will be between 3 mm to 2 centimeters. There are 4 varieties of lacunar stroke. Pure motor stroke, if the problem is in the internal capsule. Pure sensory stroke, if the problem is in the posterior ventral lateral nucleus of the thalamus, if the infarction is at that area. Sensory motor, that is thalamo-capsular. Both thalamus and capsule will be involved. Then ataxic hemiparesis, where internal capsule and basis pontis infarction will be there. Then dysarthria, clumsy hand syndrome, where the basis pontis and internal capsule will be affected. Again there. Age and hypertension are the risk factors for lacunar stroke, and treatment is same like any other ischemic stroke, and it is CT diagnosis, lacunar infarction. Prognosis is good. So next, coming to the treatment, how do you manage a case like this? Okay, after discussing the treatment of ischemic stroke, briefly I want to tell about the intracerebral hemorrhage also. So first is medical support. Whenever a patient comes like this, you are first to prevent the complications like developing pneumonia, aspiration, bed sore, DVT and pulmonary embolism. So you have to give a pneumatic stack compression or heparin dosage to prevent DVT, rice tube to prevent aspiration and pneumonia. Skin infection you have to prevent, and bed sore you have to prevent by giving a water bite. UTI you have to prevent. Blood pressure, how do you control? You should not reduce the BP if it is not more than 220 by 120 or 185 by 110 if you want to thrombolyze, because the autoregulation of the brain is set at a higher level in stroke patients. Reducing the BP is detrimental. Fever and hyperglycemia is detrimental. You have to treat fever. Sugars you have to maintain around 180 mg per deciliter. Then brain edema. Brain edema starts usually at 2nd to 3rd day. It peaks around 2nd to 3rd day and it may remain there for 7 to 10 days. You give a mannitol to reduce the brain edema, or hemicraniectomy if it is very severe. The whole idea of all these things is to prevent the ischemic penumbra from undergoing the infarction. What is ischemic penumbra? Ischemic penumbra means infarction has not occurred by doing a diffusion MRI, but only perfusion will be a problem when you do a perfusion MRI. So a mismatch between diffusion, perfusion, MRI. Perfusion defect will be very large, diffusion defect will be small. That means there is some area which you perfuse the arteries, you can save. That is ischemic penumbra by treating fever, sugar, BP, ICT, these kind of things. So this is a medical line of management first thing. Next is thrombolysis. Whenever ischemic patient like this comes within 3 hours, especially in US, as in US 3 hours, in Europe and Japan 4.5 hours, you have to thrombolyze with that RTP, tissue plasminogen activator. The dose is 0.9 mg per kg body weight. Maximum dosage is 90 mg. 10% you will give as a bolus, the rest over 1 hour. But in India and other Japan countries, they give 0.6 mg per kg body weight because the body mass weight and increased risk of hemorrhage. What are the indications and contraindications for thrombolysis? Indication is patient should have a stroke. CT should not show hemorrhage, should have been ruled out. Hemorrhage should have been ruled out. There should not be more than 1/3 of the edema involved in the MCA territory. Age should be more than 18 years and consent should be given by a surrogate bystander. What are the contraindications? Blood pressure more than 185 by 110, platelet less than 1 lakh, PCV less than 25, blood sugar less than 50 or more than 400. Use of any anticoagulants in the last previous 48 hours, surgery in less than 14 days, bleeding, bleeding 21 days, last 21 days. Any previous stroke, trauma, hemorrhage in last 3 months is a contraindication for thrombolysis. Minor strokes, stupor or coma, rapidly improving symptom is a contraindication for thrombolysis, and recent MI is a contraindication of thrombolysis. So what you will do, you will put a 2 cannulas, avoid central line and arterial line, then they have to fall into all the categories. Contraindication should be ruled out. Never catheterize 2 hours after giving thrombolysis. Don't give any anticoagulants for 24 hours. So this is IV thrombolytic therapy. Next is endovascular treatment. You can thrombolyze intraarterially. You can put a catheter intraarterially and you can give the drug there. But FDA has still not approved that. Intracatheter thrombolysis has not approved it. And one more endovascular therapy is carotid endarterectomy. Those who are having contraindication thrombolysis, or after thrombolysis also, if the artery is not recanalized, in them you can do carotid endarterectomy. So that is endovascular therapy. Next is antithrombotic treatment. Aspirin is the only antiplatelet which can be used in acute management of a stroke, okay, which is having beneficial role. Anticoagulant like heparin, only some indications. Routine use of anticoagulant like heparin is not indicated in the stroke patients. If they have a embolic source, is their AF thrombus, you have to give anticoagulant. Then cortical venous thrombosis postpartum, heparin is indicated. Earlier books used to give vertebral dissection. Anticoagulants are better than aspirin, but latest edition Addison says both are equally efficacious. Heparin has no added benefit compared to aspirin, so no need to give heparin for vertebral artery dissection. Then stroke in evolution, you can give heparin. If it is increasing the weakness, you can give heparin. Then for secondary prevention with the anticoagulants, I will discuss in the secondary prevention how to give and what is CHAD score and other things. The neuroprotection, the glutamic acid is an excitatory amino acid which can damage the neurons, but studies have not shown any beneficial effect of the neuroprotections. Then you have rehabilitation, as I told, to prevent contracture, physiotherapy, very important, to prevent DVT, to prevent pneumonias. And stroke centers, you can take the help and you can treat. Coming to the secondary prevention, again aspirin you have to give. Aspirin and clopidogrel within 21 days you can give, but a long-term aspirin and clopidogrel is not indicated for a secondary prevention. Only aspirin is enough. Dose is from 75 to 325 milligrams you can give. Then anticoagulants, what are the indications to give? So in atrial fibrillation, how you give anticoagulants is depend upon by CHAD VAS score. C is congestive heart failure 1 point, hypertension 1 point, A age more than 75 years 2 point, 65 to 74 years 1 point. D diabetes mellitus. V other vascular diseases like recent MI, peripheral vascular disease or aortic plaque. Then stroke, if there is any TIA or if there is any hemiplegia or any aphasias or TIAs, you will give 2 points for stroke. Then female sex 1 point. So CHAD VA score. If score is 0, either aspirin or no oral anticoagulants. If score is 1, either aspirin or oral anticoagulant. If score is 2, you have to give oral anticoagulant. The novel oral anticoagulants like dabigatran, rivaroxaban, edoxaban, apixaban, you can give only in non-valvular AF. In rheumatic MS and all, you have to give only vitamin K anticoagulants like warfarin, acetron. Similarly with mechanical heart valves, you have to give only vitamin K anticoagulants like warfarin and acetron. The novel oral anticoagulants in a rheumatic valvular disease and mechanical valves is not studied. So then endovascular therapy for prevention, again I want to discuss. For asymptomatic carotid stenosis, the endovascular therapy with the carotid endarterectomy is not indicated. For symptomatic patients, more than 70% it is beneficial. Between 50 to 70% also it is beneficial. Less than 30%, even if it is symptomatic, it is not beneficial, carotid endarterectomy. Those who are more than 75 years, severe internal carotid artery stenosis, and those who come early within less than 2 weeks, endovascular endarterectomy, carotid endarterectomy is beneficial. The benefit depend upon whether they had a retinal deficit or hemispheric deficit, what is the time approach they came, then the operative efficiency of that institution. If it is more than 6% mortality, you should not do carotid endarterectomy. Then if they have the comorbid conditions like a cardiac, pulmonary, age more than 80, contralateral laryngeal nerve palsy, radical neck dissection or radiation therapy to the neck, then you have to do balloon angioplasty and stenting rather than carotid endarterectomy. Okay, students. Now let us discuss about the hemorrhage. Few points about hemorrhage. So I want to tell briefly about intracerebral hemorrhage. What are the causes of intracerebral hemorrhage? The trauma is the commonest cause of intracerebral hemorrhage. Hypertension, then hemorrhagic transformation of the infarction, ischemic infarction. Secondary metastasis like a choriocarcinoma, lung carcinoma, renal cell carcinoma can bleed. Cerebral amyloid angiopathy. Drugs like amphetamine and cocaine. Cavernous angiomas. Dural AV fistulas. Capillary telangiectasias. AV malformations. Aneurysms. And coagulopathy like hemophilia. These are all the causes of intracerebral hemorrhage. Next is what are the clinical features? Some of the clinical features I want to discuss. Hypertensive hemorrhage is usually common in putamen. Next is thalamus, pons and cerebellum. So if internal capsule is involved, patient will have the hemiparesis and hemiplegia. Then if thalamus is involved, the contralateral one side of the body, the loss of all the modalities of sensation. Thalamus is nearer to internal capsule, so even it may press, it may also produce hemiparesis. If the thalamic infarction extends into the midbrain, there are some eye signs. There may be skew deviation, the eye may be downward and internally rotated. There may be a loss of convergence. Horner syndrome may be there. And pupil may not react to light properly. And convergent retraction isthmus also, they may develop thalamic hemorrhage. The contralateral loss of sensation but severe pain, that is known as anesthesia dolorosa. Another name is Digery and Lucy syndrome for thalamic syndrome because of the hemorrhage. Pontine hemorrhage, they will have a pinpoint pupil, bilateral pinpoint pupil, quadriparesis, hyperpyrexia. So 4 P's: pontine hemorrhage, pinpoint pupil, hyperpyrexia, paralysis, quadriparesis. If they recover, they can have a locked-in syndrome, but if comatose, most of them will end up in dying. Cerebellar hemorrhage, they will have ataxia, nausea, vomiting, ocular bobbing, ipsilateral gaze palsy, 6th nerve, abducent nerve, and can undergo paralysis. Then in AC and MCA territory, whichever side the hemorrhage is there, the clinical feature what I discussed in the infarction, same thing will apply to hemorrhage. What all I discussed in the AC and MCA territory, corresponding areas, if hemorrhage is there, they will have clinical feature in that area corresponding to that area. Okay, next, how do you treat the intracerebral hemorrhage? Control the blood pressure till 140. They grade the prognosis by giving a ICH score. Nowadays, the recent edition of Harrison gives ICH score. Depending upon the age more than 80, less than 80. More than 80, 1 point, less than 80, 0 point. Amount of the hematoma, more than 30, 1 point, less than 30, 0 point. Intraventricular or not? Intraventricular 1 point, no intraventricular 0 point. Supratentorial, infratentorial. Infratentorial 1 point, supratentorial 0 point. Then Glasgow Coma Scale. 3 to 4, 2 points. 5 to 12, 1 point. 13 to 15, 0 point. So if low platelet is the cause of hemorrhage, give the platelet. If vitamin K anticoagulants is the problem, you give prothrombin complex concentrate or fresh frozen plasma. Then they have tried, so if blood pressure, you control the blood pressure till 140/90, you can control the blood pressure. They have tried the surgical evacuation for the cortical hematoma, supratentorial. They have found in medical management is better than the surgical evacuation of the hematoma. So routine evacuation of hematoma in a stable patient is not indicated. But the evacuation of hematoma is a must in cerebellar hemorrhages if the size is more than 3 cm. Because it will produce a coning, brainstem compression and death. If it is between 1 to 3 centimeters, the hematoma, cerebellar hematoma, you observe the patient. If they develop drowsiness, then you evacuate it. That is the surgical treatment of intracerebral hemorrhage. So I covered the etiology of ischemic stroke, clinical feature of MCA and ACA, treatment, lacunar infarction, blood supply, intracerebral hemorrhage. One question which they ask in the exam is what is the function of parietal lobe, dominant and non-dominant lobe? The dominant parietal lobe function is calculation, Then it has long range function, stereognosis. Because if dominant lobe is affected, they'll have aphasia. Long range prolong will be there. Acalculia will be there, Justman syndrome. Non-dominant lobe, dressing apraxia, construction apraxia, which I told you. So they develop apraxias and visuospatial orientation will have non-dominant lobe, the function. So if that is affected, they will have visuospatial disorientation, hemi-neglect. This question they will ask, dominant, non-dominant, parietal lobe function. You should know. So for this case discussion, students, I want to keep only anterior circulation. Posterior circulation is mainly a postgraduate topic, which I'll discuss detail with the thalamic infarction patients, all the syndromes. Two more things which you should know is stuttering hemiplegia and amaurosis fugax. Stuttering hemiplegia is there will be increasing in the frequency of the TIS followed by a hemiplegia due to internal carotid artery atherosclerosis. Amaurosis fugax is due to internal carotid artery occlusion. If there is embolism to the ophthalmic artery, they will have ipsilateral monoocular blindness, monoocular vision loss. That is amaurosis fugax. It could be a TIA, a transient ischemic attack. Then it recovers. Amaurosis fugax. One more thing is carotid stroke. Carotid stroke is ipsilateral blindness, contralateral hemiplegia. Because ipsilateral internal carotid artery supplies the ipsilateral MC, contralateral hemiplegia. Because this internal carotid artery gives us the MC on the same side. So they have contralateral hemiplegia. Ipsilateral eye may be involved. That is carotid stroke. These are some of the questions which you can expect in hemiplegia case discussion, students. Thank you.
Hello students, today we will discuss few points about cerebrovascular accident. Already we have discussed a classic case of hemiplegia. So a few points about cerebrovascular accident I have to discuss after the case discussion which I have done. So first is the blood supply of circle of Willis. So here in the examination they will ask how circle of Willis is formed if you get a hemiplegia case. So you have to know about that, students. So here you can see internal carotid artery. This is the internal carotid artery. Internal carotid artery gives middle cerebral artery, which is the main branch, and then you have internal carotid artery also gives anterior cerebral artery. Anterior cerebral artery. Two anterior cerebral artery will be connected with the anterior communicating artery here. Okay. And you also know that internal carotid artery gives the terminal branch ophthalmic artery. Internal carotid artery also gives anterior choroidal artery. So the anterior circulation is formed by the middle cerebral artery and anterior cerebral artery. These two are the main blood supply of anterior circulation. Now you have here the basilar, two vertebral artery joined together to form the basilar artery. This is the basilar artery. It gives the pontine branches. Here you can see the pontine branches. And also the basilar artery, the terminal branch is, it divides into two posterior cerebral arteries. Two posterior cerebral arteries. Okay. So here you have from posterior cerebral artery communicates with the internal carotid artery, posterior communicating artery. Posterior communicating artery. Basilar artery, you can see here the one more branch, the superior cerebral artery, the basilar artery branch, superior cerebral artery, you can see here. So this is circle of Willis. So it formed by the middle cerebral artery, anterior cerebral artery, posterior cerebral artery, and two anterior cerebral arteries are communicated with the anterior communicating artery, and the posterior cerebral artery will be communicated with the internal carotid artery by the posterior communicating artery. This is the circle of Willis, students. So this in the examination they will ask and you have to be thorough with this. Okay, right. So next is the blood supply of the cerebral cortex. You should know about this. So they will ask here. So this is a lateral surface and this is a medial surface of the brain. See here in the lateral surface of the brain, you can see that the pink color is the middle cerebral artery. The majority of the parietal lobe, the superior part of the temporal lobe is supplied by the middle cerebral artery. Only a little part in the lateral surface, the yellow color, is supplied by anterior cerebral artery here. Okay, and the blue color is the posterior cerebral artery. Is the blue color, the occipital lobe and the inferior part of the temporal lobe is supplied by the posterior cerebral artery in the lateral part of the brain, students. So come to the medial part. Here you can see that the medial part mainly is supplied by the yellow color, the anterior cerebral artery, the most of the part of the medial part of the brain. And then the occipital lobe is supplied by posterior cerebral artery, so the medial part of the brain. Okay, students, so this is the blood supply of the cerebral cortex, they may ask. So next is they'll ask blood supply of the internal capsule, which is very important. If you get a hemiplegia case, definitely they'll ask blood supply of the internal capsule. So internal capsule is divided anterior limb, genu, posterior limb and retrolentiform parts, students. So this is how you have to write the diagram: anterior limb, then genu, then posterior limb and then retrolentiform part. Here you can see the pink one. The main part in the pink, the anterior limb upper part, the genu upper part and posterior limb is supplied by the striate branches of the middle cerebral artery. The striate branches of the middle cerebral artery. Okay, students. So that is the MCA branch, striate branch. Then here you can see the retrolentiform part and the inferior part of the posterior limb is supplied by anterior choroidal artery, which is a branch of internal carotid artery. Internal carotid artery. Okay. Then the genu, the lower part, the light yellow color, you can see it is supplied by branches from the posterior communicating artery. Posterior communicating artery. Then in the anterior limb, the inferior part is supplied by recurrent branch of the anterior cerebral artery. So this recurrent branch of the anterior cerebral artery is also known as Hubner artery. Hubner artery, students. Okay, so this is the blood supply of the internal capsule. So middle cerebral artery striate branch, the anterior choroidal artery internal carotid artery branch, then posterior communicating artery branches the genu, and the inferior part of the anterior limb by the recurrent branch of the anterior cerebral artery. So you can remember like MICU. M is a middle cerebral artery, I is a internal carotid artery, anterior choroidal branch is a internal carotid artery, C is a posterior communicating artery, and A is a anterior cerebral artery recurrent branch. So this is how you remember the blood supply of the internal capsule. Definitely they will ask in the exam. You have to know both undergraduates and postgraduates if you get a hemiplegia case. So this is a CT scan showing the infarction, students. Here you can see hypodense area. Here you can see here the marked in the red color hypodense area. This is the infarction. This is the infarction. The hypodense area. This is how we look the infarction in hemiplegia if you take a CT scan, students. Okay. So next is this is the hemorrhage. If a hemorrhagic patient is there, the CT scan show the hyperdense area. Here you can see the whitish thing. It is as though like a bone. How the cortical bone it looks, the cerebral the skull. Same density will be there if a hemorrhage is there. The hyperdense area you can make out if there is a hemorrhage, students. Okay, students. So these are some of the basic things which you should know if you get a hemiplegia case, especially the blood supply, the internal capsule, circle of Willis, they will ask in the exams. Okay, students. So thoroughly I discussed the hemiplegia, so it should be helpful for you to answer all the questions. Thank you, students.